Welcome to the Lighting Your Way podcast. This season, our sixth, we're talking to my colleagues at Guardian Nurses about how they help our patients navigate a very complex and confusing healthcare maze. At the end of each episode, you'll hear their suggestion as to how you can become an advocate for yourself and your loved ones. Among the plethora of clinical issues that our nurse advocates deal with on a daily basis are patients who have mental health and substance use issues. One of our nurses in Seattle, Samuel Hirst, has an extensive background in supporting these patients. We talk with him today to better understand the type of support that he offers. Good morning, Sam. This is your first opportunity to be on the podcast. Welcome to the Lighting Your Way podcast.
Hey, Betty. Great to be here. Thank you.
Yeah, thank you for getting up early, first of all, because I know I know it's 3-hour time difference, so I appreciate your effort. Sam, you are one of the nurses on our Sound Health and Wellness Trust team, our mobile care team. But you specialize in helping our patients out there with mental health or substance use issues. So I wanted to bring you on to talk specifically about the work that you do with those patients. So can you tell us, tell us what that day looks like for you?
Usually, the way we get the patient referrals depends on what stage that patient happens to be in their search for drug and alcohol recovery or mental health recovery. So if they're inside the hospital, usually it's trying to connect with the social workers there, the case managers, to ensure that they have an adequate discharge plan in place, or what's called a RAT plan, which is a wellness recovery and action plan. And if they are making a direct call to Guardian Nurses, most of the care coordination involves just trying to figure out, okay, where do you live? What type of resources are you looking for? Is it specific to actual drug and alcohol treatment, or are you just looking for a counselor or a mental health professional to help kind of guide you through the process? And it can be anything from setting them up with an acute detox bed to just helping coordinate with case managers from all over the West Coast, really, to get them into a treatment center that fits with their finances and their ability to enter a treatment program.
Wow. So that has got to be one of the probably the most challenging, is to find an appropriate detox, right? Is that true?
Yes. Yep.
Yeah, and all the patients that you work with are insured. So that's hopefully,
correct. Yep.
That helps a little bit. But are you finding that when you call the hospital to talk or a facility to talk with a case manager or a social worker, that they're receptive to your call?
It really depends. If I'm engaged with the patient prior to them going into a treatment facility, it's a lot easier. But once they're already there, the privacy laws are set up in such a way that they're not really allowed to communicate that the patient is even at the facility. So it's a lot of kind of back channel navigation with connecting with maybe their family first to see if they can call them in the treatment facility so that we can help, transition them back to general living once they're out of the treatment program or hospital setting.
Do you feel like there's mostly the patients that you deal with, are they, I know that they can be dual diagnosis, but where do most of the referrals come from? Are they mental health or are they substance use?
I would say 50-50. There's been a handful, they, like you said, they go hand in hand. So it's hard to really get down to the final diagnosis when, a lot of the behaviors and symptoms can possibly be attributed to both, if that makes sense.
Right. No, absolutely. I think that's what we self-medicating, right? That's what we call that. Sam, is there anything unique about Seattle in terms of patients using drugs or the drugs that they're using? Like I know you and I talked when you were out here recently about the what we're seeing in Philadelphia, which is the use of Trank on the streets. Has Trank hit Seattle?
Yes. Yeah. And it's hard to figure out whether or not it's actually in the drugs. I've spoken to a few people at the jobs that I previously held just to get an idea of the amount that they're seeing. And just anecdotally, when they've started testing the urines of patients who are coming in, they're finding maybe 10 to 20% are testing positive for tranq, which is xylazine, which is a veterinary alpha-2 agonist, which is causing a lot of issues out here as well. It ends up leading to a lot of skin issues, but the main thing is the withdrawals. So if you're coming off of a lipophilic opioid like fentanyl that also contains this alpha-2 agonist like xylazine, and you're trying to treat the opioid withdrawal with an alpha-2 agonist that would typically be used for opioid withdrawal, it can become an issue. So it's trying to treat the acute withdrawal process is becoming a lot more challenging as well.
Wow. So this is tranq is xylazine, which is, you said it's an animal tranquilizer?
Yeah, it's like the veterinary version of Precedex, which is a sedation medication used in the hospital setting in the ICU.
Wow. So the drugs that the people are using is laced with tranq. It's not necessarily full tranq.
Well, I think probably a little bit of both. It's hard to tell, but yeah, I think the majority of it just gets laced with it. And so it's hard. Yeah, I think they added it in to extend the amount of time of the high, because fentanyl in and of itself, the reason why it's preferred in the hospital setting is because of those lipophilic properties. So enters the brain really quickly and leaves the brain really quickly. So, which is why patients end up having to use the opioid fentanyl, every hour, every 2 hours to maintain that sense of well-being and normalcy.
Wow. I know that the media reports here in Philly on that, and certainly in New York as well. It's a pretty compelling look on the streets of somebody bent over, kind of out of it. Yeah.
Yeah. A lot of methamphetamine out here as well.
Okay.
Yeah, which is interesting. There's at the beginning of this year, a physician at the Providence Hospital in Everett in the ER participated in a drug trial for a monoclonal antibody specifically to target methamphetamine, which I thought was pretty cool. And there's some promising developments with that. Yeah, so somebody comes in acute psychosis, they're able to give them this monoclonal antibody treatment and basically get them back to a normal state within just 30 to 60 minutes.
Wow.
I haven't followed up to see what the results of the trial are, but the length of time that it stays in the person's system can be upwards of 30 days. So it minimizes the risk for, relapse, and kind of gives them a bit of hope to find housing later on.
Do you feel, certainly there's been more attention in the last couple of years toward mental health because of COVID, but with drug use and substance use disorder, there seems like, for instance, what you're talking about, a clinical trial, is there more energy going into the type of treatments that we're seeing as opposed to just blaming the patient and, letting them detox on their own?
That's hard to say. I think there's always new stuff coming up, but it all comes down to, the funding aspect. And I think in general, it's just, there's not enough money in the world to throw at research to help, because again, the money aspect and then the resources with healthcare professionals and nurses that understand it, but that can also tolerate the day-to-day trials of working with a population that's at their lowest. So if you can find a provider or nurses that have a heart for this population, that's, I think, would be a big help as well.
True. So, Sam, you also deal with support our medical cases, if you will, besides the substance use and mental health. When you're dealing with patients who, I want to say just have a, a medical clinical issue,
right.
Are you seeing more of those patients needing mental health support post-COVID?
Yes and no. It's, I think if it's a critical diagnosis, obviously there's going to be some fear and some depression that might go along with that, or anxiety in general. But a lot of the times, they're so caught up with the immediate treatment for, maybe a new cancer diagnosis, that it's not until, a few months after that you're wanting to try to help them get to see a therapist, or figuring out when the right time is to maybe bring it up. Of course, if they're asking directly, it's easy because you can just help them right there. But
Right.
Establishing a relationship with the particular member, and then just kind of seeing where their head's at in general. But anytime they ask, it's the first thing you want to do is try to get them the help they need.
Yeah, which is not always that easy, right? I mean, given what, the challenges of the funding and challenges of availability of the providers. That's I know out here on the East Coast, that is one of the greatest challenges, to find someone who participates with the insurance, who is accepting new patients, and you could get them in to be seen within 6 months. That's the biggest challenge. So how are you feeling in general about, I'll say, the state of healthcare as it pertains to mental health and substance use? Do you feel like you've been in the field for a while, so give me a sense of.
I mean, every week is different. There's some weeks where I can hit a home run and get somebody what they need really quick, and other weeks it's remains challenging because you're trying to do a lot of this navigation from different counties. And then patients have their own lives with their own, socioeconomic struggles or mental health struggles. So it's just a lot of challenges, but it's definitely worth it when you're able to get people what they need. Within the time.
Yeah, I've always said, while healthcare in general is difficult to navigate, mental health and substance use is even worse, right? Because I call it the black hole. It is not easy for all the reasons that we've mentioned. So, what, like, when you think about the number of people that you've helped in the course of the last year with Guardian Nurses, but also prior, is there any one case that stands out to you?
I don't know if there's a particular case, but there's definitely been cases back in my detox days where we'd have patients show up in an Uber and they'd overdose in front of our building, and we'd have to run codes. And when you were able to get them to the hospital, and they're able to come back and finish their detox within 5 days, those are always home runs to know that they're getting into treatment and living to see another day. Or when I get calls for patients in crisis that often they don't know what's really going on. They're in their mind thinking that they're losing their mind, and their family, who's unfamiliar with just mental health in general, let's say it's an acute manic episode, it's a lot of conversation with the family to just say, hey, there's probably a lot more going on with your family member that you're not seeing, and it's just one of these things that you have to encourage them and support them and make sure that the entire family unit's kind of on board with what's going on, similar to, I guess, a cancer diagnosis, because it obviously affects everyone.
In a pie in the sky type of thing, Sam, what, and I know there's a lot of tricks and tricks of the trade that you have, but if you were, the king of the world, what one benefit would you like to see offered to patients without regard to insurance as it relates to your specialty?
I think if insurances would pay for longer detoxes, I know for private insurance, there's ways to get concurrent reviews where they can, push out the length of time for the withdrawal. With state funding, they have this number, 5 days is it. And like with fentanyl, they're not really hitting their peak withdrawals until maybe day 4 or day 5. So I think just in general, if patients are really wanting to recover, if there could be, blank checks for 6 months programs, and then getting patients back into society to where they're able to make those connections in such a way with other people that they essentially don't want to go back. Because I think part of the issue with recovery from drug and alcohol substance use disorder is you can get through the acute withdrawal stage, and they'll end up feeling really well for the first few months after that, but it's really the remodeling of the brain and that limbic system beyond that, maybe 28-day program that people are traditionally prescribed. If they can get to a point where they're feeling comfortable back in normal society, so getting them in a program for that 6 months, maybe a year, but then along with that too, you get people wanting to get back to work and reestablishing their lives, and so they don't often want to go away for that 6 to 12 months. So I think if they're younger, if they're in their teens, early 20s, that would be one benefit. Just saying, hey, let's make programs that are a year long, and then really surround them and figure out how to get them back home after that 12 months.
Oof. That's well, I hope that does at some point. At least 5 days does seem really short, right?
Yeah.
To detox and then to 5 days is really short. Sam, do you remember, if you can, how old was the youngest patient that you ever helped? Just out of curiosity.
18.
18. Okay. Yeah, I know it's happening a lot sooner these days. It's a lot more available. Yeah. There are so many questions that I would like to ask, but I want to keep on time. But I do want to ask you if, for our listeners who might have someone in their lives with mental health or substance use issues, what is if there is, or you can have two, what is the one piece of advice that you would offer them?
The opposite of addiction is connection. And if you can surround those people when they're at their lowest and let them know that they're worthy of love and deeper connection with other people, and that their behaviors in and of themselves, won't be held against them, I think that would allow for a lot of recovery.
Wow, that could be used for anything. That's wonderful, right? I mean, certainly I appreciate the opposite of addiction is connection.
Yeah.
Wow. Well thought. Well put, Sam. Well put. So that's all the time we have, and I'm sorry for that, because I think this is probably a lengthier discussion, but there's an opportunity for you to come back now.
All right.
So thank you, Sam, for joining me and for having this important conversation. And I really appreciate your perspective on the work that you do. Thank you for all the help that you provide our patients.
Well, thank you so much, Betty. I enjoyed it.
If you have any questions that you would like us to address in a future episode, please email us at podcast@guardiannurses.com. That email again is podcast@guardiannurses.com. We would love to hear from you. Thank you for joining us this week. You can find the Lighting Your Way podcast on Apple Podcasts, Google, YouTube, Spotify, and Stitcher. If you liked what you heard, tell a friend and leave us a review. You can learn all about Guardian Nurses Healthcare Advocates on our website, guardiannurses.com. So until next time, find some joy in your life, pet all the good doggies and kitties, and remember to tell your people that you love them. Take care.